nephrolithotomy, renal access, both fluoroscopic and ultrasound techniques, as well as a little bit of information about anatomy. So just quickly, I'm helping these telemedicine companies out during the COVID crisis with some advice, but otherwise no disclosures. So urologists perform percutaneous access infrequently in the United States. And what I'd like to demonstrate with my talk, or hopefully convince you, is that having the urologist perform access is not only attainable, but it may be preferable. Obviously, that depends on your case volume and unique situation, but I certainly think it should be within our skill repertoire as practicing urologists, especially if we treat stones. So I'd like to demonstrate a variety of techniques today and hopefully get you a little bit more comfortable with perhaps some techniques you didn't know before. So we'll talk about anatomy, we'll talk about fluoroscopic access, ultrasound-based access, as well as some basic techniques for interpreting and performing ultrasound, doing access and dilation under ultrasound, and we'll talk a little bit about some of the research we did at UCSF regarding learning curves and outcomes. I do want to thank Tom Chi of UCSF for the videos and data for the ultrasound slides. So starting off, especially for residents, it's important to think about the kidney not just, during laparoscopic cases behind the colon and all this, but also when you're thinking about the patient's back, you want to recognize some landmarks. So we have the 12th rib, the right kidney is going to be a little bit lower there. You're going to have a variety of muscle layers overlying the kidney depending on if it's the upper pole or the lower pole. You're going to have the upper pole occluded by the intercostal muscles, whereas the lower pole, you won't have to deal with the ribs. There's fascial layers that we have to think about, especially the lumbodorsal fascia. And really, the paraspinous muscles are going to prevent any access too close to the spine. So here we can sort of see a stripped down version of this with a lumbodorsal fascia that we have to dilate through during our access. This fascial layer can prove problematic, especially in people who have had repeated procedures, multiple PCNLs. This will be very thick. You'll need a balloon that can accommodate a very thick fascia to dilate that. We want to recognize that there's the intertransverse muscles that are on the medial aspect of the kidney, and the kidney does extend up even sometimes between the 11th and 10th rib. These are different on each side, with the right kidney being a little bit lower due to the liver in the way. And so when you're approaching a kidney for access, you want to think about which side you're on and, take a look at the CT scan, assess where the pleura is, assess where the liver is, the spleen, colon. It's not uncommon for patients who require PCNL to be wheelchair bound, contracted. Patients with severe, neurologic illnesses like MS may have very collapsed lung volumes. Their kidneys may be quite high in their chest. So, this is right out of Hinman's if we're thinking about our landmarks. You have the dotted line representing the paraspinous muscle. You have the 12th and 11th ribs, where if you're planning upper pole puncture, you're going to position the needle pointing inferiorly, sort of in that area where the X is at the medial aspect of the kidney between those two ribs. I prefer a lower pole access for most of my stone cases, and what I usually do is I mark out the posterior axillary line, the 12th rib, the paraspinous muscle, and the iliac crest to make my little window where we can start to look for the kidney. So, moving forward, I don't know how to get this annotation thing off. Hang on. Okay, so moving forward, if we think about, the cross-sectional view of the kidney, it can be confusing on fluoroscopic images to identify the anterior calyxes and the posterior calyxes. And this is, one of the things that a lot of people have a problem with when they first start getting access, is perhaps they position the needle towards what looks like a really favorable calyx, but in fact that calyx is more anterior. And sometimes those anterior calyces are prime targets because the contrast that we inject is denser than urine, and so we'll sink downwards in the dependent position. And if the patient's prone, the dependent calyx will be anterior. You're not going to see the posterior calyx, and you're going to aim for the wrong spot. So what ends up happening is if you want to hit that posterior calyx, you're not going to have any problems as long as you can see it. And you'll have a nice access where you can get into the whole pelvis, down the ureter if you need. But if you go towards an anterior calyx, what will happen is you'll go right through those interlobar arteries, and you can get a lot of bleeding. You'll maybe not be able to get at your stone. And in the worst case scenario, if you're going for a medial anterior calyx, you can go right through the renal vein. And it's happened before where you put the needle in, you take out the stylet, and it just comes back frank blood. And what you do in that situation is just remove the needle under no circumstances should you be dilating. Now, shifting view a little bit, towards a clinical situation, it's not uncommon that you get an access where the radiologist placed the tube and you don't know where that's going. And so it's very important, especially for the residents, to think about how the puncture may not be in your best interest. In this case, the IR attending was a new attending. He saw that posterior lower pole calyx, but put the needle through and through into the lowest most infundibulum. And if we had not recognized that and dilated that tract, that interlobular artery would have been severed. The patient would have had a bad outcome. So it's very important to reposition such an access. And here you can see we replaced that into that posterior lower pole calyx. Now, considering from the coronal view here, or like more of a longitudinal view, we have these blood vessels that course through the kidney, and we'll talk a little bit more about why the kidney has its distinct shape. But if you go for the wrong calyx, like I'll show you a clinical example in a minute, what can happen is that you'll end up going into a lower pole calyx, and if you're not careful, you'll say to the interventional radiologist, can you please get me a lower pole access? And they'll oblige, they'll get you this calyx. And what happens is you go right through that artery when you dilate, crack the artery, you get bleeding, and you're having to make a 90-degree turn just to get to your stone. Perhaps a better course of action would be to position your needle here, and that's a little bit more of a straight shot. What does that look like clinically? Here's an example. So, this patient was asked to have a lower pole access done. The radiologist placed the lower pole access, but as you can see, it's entering at the kidney at a right angle, just like we would expect. If we dilate that tract, maybe have a little bit more bleeding, have a little bit of difficulty getting that rigid nephroscope into the upper pole. By repositioning into a posterior lower pole calyx, like you see on the right, you'll sort of understand that maybe you have a more direct shot to the stone in the upper pole, you can get to the ureter. One thing to point out here is that this posterior calyx that we're seeing the nephrostomy tube on the right side of the image going into is not directly visible on the left side of the image. The reason for that is the dependent contrast was not filling that part of the collecting system, and this calyx wasn't even visible except on ultrasound. So that's another thing to consider. So I think a lot of us take for granted the anatomy of the collecting system. Schultz in 1987 sort of did a cadaver study where they looked at hundreds of cadavers, and they mapped out and classified the collecting system of many of these patients. They looked specifically at stone-forming patients and noted that there were a different. So first of all, we're talking about the major calyces and the minor calyces and how they come together. So what they ended up describing is that for stone-forming patients, the most common pattern was the bottom middle pattern, so this 3-calyx pattern, where you have 30% fewer dendritic types, so that's 2A, top left. You have 31% more transitional renal pelvises, so that's where you have compound calyces coming together and large minor calyces, small minor calyces joining into one large major calyx. And then you tend to have a lot more of these lower, mid, and upper pole systems as opposed to those really spider-like systems that we sometimes see in non-stone forming patients. Now, what's the reason for all of this? Well, during nephrogenesis, the ureteral bud travels sort of proximally towards the metanephric blastema, and this initiates a division process. The first division that happens is mediated by both RET and GDNF genes, and the first division is in a superior-inferior direction. So you get the upper pole and you get the lower pole. Those buds then grow longitudinally, they get longer, and then they divide again and again and again. So ultimately, the first poles to develop are the upper pole and the lower pole. The last poles to develop are the mid pole. So it's not described, but it's theoretically plausible that stone-forming patients have a different level of expression or perhaps a polymorphism in these or similar genes that affect the branching pattern of the renal collecting system. So Dr. Stoller as well from UCSF, before I got there, looked at hundreds of people's CT scans to sort of classify what's the best calyx to puncture. And he always would say door number 2, and I never quite understood that until looking at this figure. But if you take a retrograde image of the patient prone, the calyx number 1 on the left is going to be oriented in the axis of the kidney, so in the up-down axis, and it's going to be not posteriorly located. When you shoot your fluoroscopic retrograde, you're going to think that number 3 is posteriorly located because it'll light up first. It looks appealing. But it's really the one in between those two, number 2, that's posteriorly located. It's just very important to make sure you get good distension so you can see that. So what we see in the middle is a 3D reconstruction of the same kidney. And you can sort of see that calyx 2 is pointed towards us, and you see the spine here suggesting that towards us is posterior. And then if you rotate our fictional C-arm, you'll see that that calyx is posterior, and the line of the arrow would be our preferred percutaneous renal access. So there's 3 main techniques to do fluoroscopic guided PCNL access. So we can do eye of the needle, we can do triangulation, or we can do a combination of techniques, which we'll call pseudo-triangulation. So eye of the needle, I think, is probably what most people across the country are doing that do fluoroscopic guided punctures. The basic technique here is that you identify your target calyx, you position your needle on top of that, and you orient your C-arm in line with that calyx, so 15 degrees towards the operator. You then orient the needle such that it's a pinpoint, that you're looking down the eye of that needle, like a bullseye. You then rotate your C-arm perpendicular 15 degrees to that needle so you can assess your depth. You then advance the needle a certain amount, and you can check the depth based on this AP view. Now the problem with that is if you look on the bottom right image, the fluoroscopic image, you'll see that the needle is not going in the same orientation as the calyx. Because the C-arm relies on going only rainbow towards you or away from you, it doesn't look in the orientation of the calyx. So by definition, your needle trajectory is always going to be perpendicular to your C-arm, but not necessarily in line with your calyx. And I think that's a big problem. Perhaps a better puncture for this particular kidney would be in that direction. So how can we achieve that? Well, triangulation is also described in Hinman's. It's one way to do it. I find the way that they describe it here to be a little bit counterintuitive, where you have to rotate the C-arm in 2 different planes to sort of see where your needle is. So I've done this technique. I find it a little bit confusing. So what I think works a little bit better for me is what we're going to call pseudo-triangulation. So here we're demonstrating the AP view of the kidney. We have obviously a mock-up here, but they have the ribs, you have the stone, you have your collecting system, and my preferred calyx would be that second door number 2 there, that the calyx at 5 o'clock in the lower pole. So the first thing we do is we would rotate the C-arm to get a sense if that's correct. So as we rotate the C-arm towards ourselves, that calyx is going to start moving towards the top of the screen. As the calyx moves towards the top of the screen, you'll see the ribs sort of come in line with our image as well, move away from us. And if we were to keep rotating the C-arm, which we can't really do due to limitations of the machine itself, we would see that the particular calyx in question goes to the top of the screen. So if we operate under those assumptions, we go back to our AP view, we line up our needle on top of the patient, we draw a line on that area and keep the needle in that orientation for the rest of the case. We then find an area a few centimeters from here and estimate the angle we would need to go based on the body habitus of the patient. We then rotate the C-arm to get our depth. We advance the needle, and if the needle is on target, it'll look like this. If we're off, it'll be below or above our target calyx. We withdraw the needle and re-advance with a correction. So here's how this would look on our model from earlier. We have our AP view, we position the needle on top, we rotate the C-arm, and we would assess our depth. So this solution doesn't always, the solution of looking for that posterior lower pole calyx doesn't always apply. Sometimes we have to make adaptations, but fortunately this technique is applicable to other variant anatomies, and so we were able to get satisfactory upper pole access in this situation using that same technique. What I do like is the ability to orient the needle in line with the target calyx. Here we had a really nice trajectory all the way to that renal pelvis where we could get our stone. So once we're in, we need to establish that we have a wire in the collecting system. So, when you do your access under ultrasound, it can be a little bit harder to get a wire down the ureter without switching to fluoroscopy. And also, you don't always have the ability to get a wire down the ureter, especially if there's a large obstructing UPJ stone or something like that, maybe a staghorn stone. So what we can use is a coaxial coiling wire. Coil that somewhere in the pelvis or the upper pole, get enough wire in the collecting system that you're comfortable, that you're not going to immediately lose access. These wires are also PTFE coated, but not glide wires, so they stay nicely. If you can get a wire down the ureter, it's optional. I always find that it's better to underdilate an access than to overdilate. What I mean by that is you don't want to put the balloon past the infundibulum, and you don't want to advance your sheath past your balloon. What can happen is if you take this example from Hinman's, that's a calyceal diverticulum. If we advance that balloon into the renal pelvis, we would split that calyceal diverticulum open. We'd have a lot of bleeding. We could get extravasation. Alternatively, we may push the balloon into the renal pelvis beyond the mucosa and into the retroperitoneum. That could be problematic. So I would prefer to partially dilate the renal parenchyma, instead making sure that the fascia is dilated and the connective tissues, and then use a rigid grasper to spread my way in. We also need to be careful not to place the sheath too far. Here you see a simulated sheath that, if placed too far past the balloon, would take a chunk of parenchyma with it and can lead to bleeding. If you put the sheath even further, you instead take a chunk of that collecting system, which is also not a satisfactory outcome. So the next thing we should talk about is that ultrasound-guided access is achievable. The learning curve is reasonable, and I think in many ways it's preferable to fluoroscopic guided access for some things we'll talk about. So here we'll see how easy this is. So this is Dr. Chi looking at the ultrasound and the needle. You can see the needle going into the upper pole there on the top of the screen. He's in. He's going to withdraw his stylet. He has return of urine. And that's all there is to it. So it really, if you get the learning curve down, it's quite a nice procedure. So there's a few skills that we should think about. The first is how to perform an intraoperative ultrasound. Where do you stand? How do you hold the probe? How do you interpret the image? So when I do my PCNL under ultrasound guidance, I'll stand holding the probe with my non-dominant hand. So I'm right-handed. I'll hold the probe with my left hand. I use the dominant hand to guide the needle. I'll have my assistant standing at the foot so that they can manage the wire once I get access. Here on the right, we can see a kidney with the hypoechoic hydronephrosis, the hyperechoic stone. You can see posterior acoustic shadowing. And notably, anything that's towards your probe, so towards the top of the screen, is going to be posterior, so that's nice. The other thing to consider is that you always want the head of the patient towards the left side of the screen. So on this Aloka machine, that green dot signifies a dot on the actual ultrasound probe, and you can use that to line everything up. So our landmarks are similar. So we mark out our ribs, we mark out the paraspinous muscles, the iliac crest, sometimes the posterior axillary line. We want to recognize that positioning the probe perpendicular to the ribs is going to result in rib shadowing. I know Dr. Chi likes to position his probes lateral to the 12th rib and often gets upper pole access. I prefer to obtain access here in this area here, this little lumbar area. So first you position your probe in line in the axis of the patient, so from superior to inferior, and then rotate about 15 degrees to be parallel to that 12th rib. That'll eliminate any shadowing and put you in the transverse plane of the kidney. It'll also allow you to rotate your hands superior towards the patient's head or inferior towards the patient's foot to get a good view of the kidney. Often you'll need to sort of press harder than you think, so I'll brace my body weight against the bed, and so that way I can put as much of my weight onto the probe without getting fatigued. So to optimize our imaging, we have a few options. So you want to make sure there's no air bubbles underneath your drape. You can use water if you like, it's less slippery, so you're not necessarily going to have the probe slipping out of your hand. But if you use a little bit of ultrasound jelly, you can get a nice image. Not all probes require a probe cover. If the probe can be sterilized, that's ideal for image optimization. Here you can see that the ultrasound image is acquired by first positioning perpendicular to the 12th rib, correcting the orientation so that the foot is to the right side of the screen. Identifying the kidney, you can see the rib shadowing, and then rotating the probe in line with the rib. This patient is supine, so the rib is positioned from the 7 o'clock to the 2 o'clock position in this image. So we're able to see a lot of surrounding structures. So let's see if we can get this to play. Here we see as the patient's breathing, on the top left, you'll see pleura. It's the little white line that comes in, and there's posterior shadowing to that. A couple more times. Up here where the laser pointer is. Again, one more time, coming in and breathing out. So that's a nice way to avoid injury or a pneumothorax. Bowel is also visible. So here we see the twinkling of the bowel. You can see as the peristalsis happens, you get that little wave-like artifact. And of course, our access would not be near here, but sometimes people have retrorenal colons or dysmorphic anatomy, and so it's very important to be able to see the bowel when you're approaching your access. And this is not something you would be able to see on fluoroscopy. Liver and spleen, readily identifiable. This is more of a subcostal view, which would allow you to see these structures. The posterior, sort of inferior to the 12th rib view that we were talking about earlier, doesn't give you as nice of a view of liver and spleen. Always keep them to the left of the image. You can recognize, that they're almost isoechoic to the kidney, and important landmarks to consider. So there's a few skills to master. So the first skill was getting your image. The second is to bring your image and your needle together. So what I like to do is, and there's two ways to do this. You can either move the probe to the needle, or you can move the needle to the probe. I prefer to keep my probe image exactly where I want it, not move the probe, and then adjust my needle trajectory accordingly. Here, Tom is doing an upper pole access. He has the needle nicely highlighted for you. You can see that needles appear like a white line, and moving the needle can be very helpful in identifying surrounding tissue movement and making small adjustments to the trajectory of the needle to match your target. You can see he has his dominant hand holding the needle. His non-dominant hand has a C-shaped position around that probe so that you can get the most pressure on that but still have your dexterity. Hand positioning is very important as well. So here's a couple of techniques. This is for a lateral to the 12th rib puncture. For a lower, for this kind of an access, you're going to get more of an upper or a mid-pole puncture, and your calyx is going to be more laterally oriented. If you were to position the probe up here where the laser pointer is, that would be getting that posterior lower pole calyx that we talked about in our previous slides, and that's also where we would aim for fluoroscopically. There's a couple main techniques demonstrated here, which will go into depth further. There's the transverse needle placement, and there's the longitudinal needle placement. So longitudinal has the needle in the front of the probe here, and transverse has it on the side of the probe. So the transverse approach is more versatile in terms of body habitus, in terms of getting sort of more unusual access scenarios, people with ileal conduits, malrotated kidneys, not good hydronephrosis, something like that. they're all contracted, you may find you have to do this, but it's difficult because you can't see the needle for its entire trajectory. What you end up doing is moving the image to follow the needle, and you have to sort of estimate where the tip of that needle will end up based on where you start. I would say it's a little bit more difficult to learn. So the benefits are, as I said, you can avoid the ribs, you can avoid, you know, skin folds, you can get the needle in a little bit more variety of locations, but it's harder to learn. Longitudinal placement has the advantage of keeping the needle visible through its entire trajectory, so you know if you're hitting bowel, you know if you're going off of the plane of the image. But you do have only two options. You go below the probe or above the probe. And if there's a rib and hip in the way, then it can be very difficult to get access in this manner. So we talked about this. It's a little bit harder also when the skin to stone distance is long, because coming in at that particular angle, you're relying on the hypotenuse of the triangle formed between your needle tip and your probe. So here we have an ultrasound trainer. This is how we learned to do ultrasound punctures. You can see that he's adjusting the angle of the ultrasound probe to bring it in line with the needle tip, which we can see here is the needle tip. And then once he's confident of his position, he's going to adjust the needle. I prefer to adjust the needle and not move the image, and then advance the needle to match the target. So if you're confident in moving your left hand and your right hand together, you can achieve access in a variety of situations. And you can see the effect of moving the needle in and out of the plane of the image. You can really only see the tip here. That's the key. So the benefits of ultrasound versus fluoroscopy. So ultrasound and fluoroscopy allow you to accurately place a needle. There's some slight differences in the scenarios where you can do that. So fluoroscopy, you can basically get into the tip of the papilla, you could puncture the fornix, you can really have a very fine degree of control, but you may sometimes get confused about whether a calyx is posterior, anterior. If you're, using a lot of fluoro, you're going to obviously have a lot of radiation exposure. Purchasing an ultrasound machine may be an expense. That's something to consider because a lot of operating rooms do not have the diagnostic quality ultrasound machines that you need to pursue ultrasound-guided punctures, and most hospitals have CRMs available. And this is not true in many countries, however. I know in China in particular, the urologists do not have access to fluoroscopy during every case, and so ultrasound is one of the main ways they do imaging. You're also able to see colon, pleura, liver, spleen with ultrasound in ways that you really can't with fluoroscopy. So how difficult is it to learn each of these procedures? Well, existing literature suggests that perhaps learning fluoroscopy takes up to 60 cases to achieve competency. Our data at UCSF may be more suggestive of 20 cases to hit the sort of the highest point of that learning curve. I know from my personal experience, it took me about 20 cases to really feel comfortable, and obviously you make improvements with every case, so I'm still learning as we go. But certainly the first 3-4 cases, very disorienting. Then you sort of start to get oriented as to, okay, this is how I move the probe, this is how I hold my hand, and then after a while you can sort of hit any target you want. Residents also seem to do very well. Here you can see a sort of logistic prediction of the success rates, and basically after 5 or 10 cases, everybody's getting a high success rate. So we can watch a video of the whole process here, including dilation. So this is just going to play as we go. So here we see a stone in the renal pelvis. You see the posterior acoustic shadowing. Consider our anatomical landmarks, our ribs, our hip, our posterior spinous, our paraspinous muscle. We want to make sure there's no air bubbles here. If there are, you cut off the drape there. Identify our kidney. This is parallel to paraspinous, pan through, sort of see what we're dealing with. Maybe there's a little bit of rib shadowing. And we rotate 15 degrees to be parallel to that 12th rib. At this point, I would typically point the probe towards the patient's head to get a good view of the lower pole if that's where I was going to go. This is a nice lower pole calyx to access. This is a nice upper pole calyx to access. We want to remember that our hydronephrosis is going to be inside of our peripelvic fat. You see our stone here again with the posterior acoustic shadowing. So if we were going for a lower pole puncture, we'd move the probe down towards the hip. If the hip is in the way, you'll see the shadowing and you may not be able to get your needle position where you want it. Here we're demonstrating longitudinal approach for an upper pole puncture. So get the needle right on that dot. You see the little dot in the middle here that signifies the center of the probe. You orient that visually, and then you can see your needle here. You keep your target in place. You advance your needle until you're confident that you're through the parenchyma. Often you'll have to give a little pop to sort of get through that parenchyma because the kidney will move, so you need to a little bit more rapidly. You can insert a guide wire here, and you can see this on ultrasound, which is really nice. You can see it coiling right there. And that's the typical appearance that we see when we have a really nice image. In these sorts of cases, when you have an image like this, you don't need fluoroscopy at all for the entire case. One nice thing you can do is pinch the wire here to maintain access. Make a little incision. You can pass your dilator next so that you have the ability to place a safety wire if you want. Start with an 8 French fascial dilator and then move up to the 810 if you want to use a safety wire. At UCSF, we typically did not use safety wires during this part of the operation because since we're not going down the ureter, they tended to get looped around the balloons and sort of actually made the access more difficult. We back off the fascial dilator, maintain control of that wire. See that he pinches it here. Now, the dilator actually is not really visible on ultrasound, so you'll see that the wire disappears, and that's how you know how far in you are. So you can kind of see the tip there, but again, it's not really visible. What you're looking for is the disappearance of the wire. Using a safety wire for this demonstration. You can see that wire again, sort of manipulating the renal pelvis there. It's a nice view. Back to the introducer off. And now we proceed with the balloon. The nicest balloon I find is this Bard Nephromax balloon. It has a 30 atmosphere breaking pressure. It's also nicely visible on the ultrasound. So here you're going to look for that wire to disappear. As the balloon is advanced, tip of the balloon is here. That nice white line is gone. Sometimes you can see this, sometimes you can't. What you can really appreciate is as the balloon is inflated, the saline inside or the contrast inside will become readily visible on the image. So here we can see the balloon dilating the parenchyma. One nice trick to do to make sure that you're not dilating too far is if you can move the wire in and out, you'll notice that it's not bent. That signifies that you're not somewhere you shouldn't be. The sheath and the balloon are the same length. So under ultrasound, it's really important to look at your sheath as you advance because you can't always see it on the ultrasound, but when you can see the back of the balloon, you know you're in a good position. And we're in. I often will place nephrostomy tubes as well in these situations, so you can use ultrasound to do that too. So that's all I have right now. Are there any questions? So first question, when we use ultrasound, you don't place any wire down the ureter, or do you switch over to fluoro and then do that? So I actually don't typically place a wire down the ureter unless I feel that the access is very tenuous or that the kidney is highly immobile or some other unusual situation, in a straightforward case, we coil the removable core guide wire in the pelvis or the upper pole so that we can maintain the safety of that access. With regards to BMI, typically, if the skin to kidney distance is more than like 10, 15 centimeters, it starts to get harder to press down on the probe. It also varies by gender. So female patients will have more subcutaneous fat, which is easier to press out of the way, whereas your obese male patients will have a lot of perirenal fat that can be very difficult because your kidney is going to be, much further away in those patients than it will in a female patient. Regarding mini PCNL, I've seen mini PCNLs done. We don't have the set at Upstate, and I use a 24 French dilator. So everything you saw in that video was a 24 French access. We don't use the outer sheath of the nephroscope, and so a 24 French access is fairly similar to an 18 French mini PCNL access. You are able to get into most narrower infundibulae. I think the risk of bleeding is minimal compared to the 30 French. And, it is harder to dilate under ultrasound with those rigid metal dilators because you're having to press on the kidney, so you don't really know how far you're going unless you're doing that under fluoroscopy. So for those reasons, a balloon dilator is nice with ultrasound access. So in regards to accidentally moving the probe while dilating, that's a good question. So part of this learning curve that we're talking about is having the ability to adjust the image. The nice thing about the ultrasound image is live, and so if you move the image, you see it happen, and you can just move it right back. So once you do enough of these cases, you really sort of see the kidney in 3 dimensions in your brain, and you can appreciate those small movements. And that's actually sometimes part of dilating, is that you're looking for the tip of that balloon because you may not be able to get the perfect plane without moving the probe. So average time for me, I would say it's the same amount of time as we saw at the beginning of the video. Often the biggest holdup is just getting everything set up and positioned for the patient like it always is, getting the nephroscope set up. But as soon as I get my hands on the ultrasound probe, I can be in the kidney in a matter of a minute or two. It's, for me, in my hands, much faster than fluoroscopy. And you all saw twice in videos today sort of how quick that process is. You can see the needle going in live real time. You know you're in, you get urine back, and everybody's happy. So how about multiple accesses with the use of ultrasound? Definitely achievable. I can think of a number of cases where we've done that. Sometimes I would say the 95 or 98% of my cases I do with a single access. But I can think of a couple patients that had very unusual anatomy, high stone burdens, where we did do multiple access. And, it is nice to have the ability to do all of the techniques that we talked about because, if you have a patient with a really unusual anatomy, you may need to use fluoro for one puncture and ultrasound for the other puncture. And having the ability to do both at the same time is really a nice skill to have. Supine, it's pretty straightforward. So one of the videos that you saw today was supine, the other was prone. For the supine access, you can really see the collecting system just as well, and the principles are the same. So you can see the colon, you can see the pleura, you can see the ribs, and you can avoid those things. And if you can get into the kidney without hitting any of those things, you have a safe access, especially since you're looking at the calyx that you want to go into. I know I've had more trouble getting in fluoroscopically supine because everything is rotated, and those mental roadmaps that we make for ourselves, they don't apply in the same way. So if you have a dysmorphic contracted patient, it can be a little bit more confusing to try for a supine fluoro puncture than an ultrasound puncture. Yep, definitely very easy to do ultrasound-guided horseshoe kidney access. We actually just published a paper about that last month. So safe and effective, often in the upper pole. It actually may be that with ultrasound, just by the angle that you're going, the mid pole could theoretically be a little bit closer to the probe than the upper pole, but it really is patient dependent for horseshoe kidneys. Any other questions? Visualization of the renal vein. Very good question. So if you turn on the Doppler, you can visualize the renal vein. Typically with a posterior approach, we're not worried about the renal vein unless we're going after an anterior calyx. So if you're going through and through, you're going to cross that the avascular plane in the kidney, and you could end up getting into renal vein. It's happened to me. Just withdraw the needle. But typically I can avoid that. I get a CT scan first on a horseshoe kidney since there are instances of having bowel behind. I always want to have a CT scan before a PCNL. It's part of the AUA guidelines on the surgical management of stones, so that's what we do. Any other questions? For the very obese, again, sort of depends on the patient. For women, sometimes easier to do ultrasound. For the men with a lot of perirenal fat, sometimes a little bit easier to do fluoro. All right, everybody. Have a great day. Thank you so much for inviting me.
Thank you, Scott. Great talk.
Yep, thanks.
Thank you. Merci.